I want to start with the treatment for the common femoral artery, the CFA. There was a debate that I just was participating in on LinkedIn about when to use endovascular versus endarterectomy, which is a surgical procedure where they cut down and they scrape out the plaque and then sew you back up. When a doctor is is deciding whether to use endovascular or surgical, and even from the patient standpoint, how do you know which to do first or when to do it? Do you have any sort of algorithm that you use in deciding whether to send the patient to surgery or whether to perform endovascular with balloons, wires, and catheters? There was one doctor on there that said, no, endo should never be performed on the CFA because he claims that the CFA does not respond well to atherectomy, which is, roto-rooting device, or angioplasty, which is the balloon inflation. He says the walls become inflamed, quite inflamed, to quote him, and friable. I'm curious your thoughts, especially with, more advances in tools and techniques today.
No, let's start saying never say never. I mean, it's difficult to say no, and the vascular is not functioning with CFA. Even today, which the advancement and the development of new devices allow us to treat as a CFA in some cases pretty well. So I think it's difficult to say there is a protocol. First time endo, second time open. No, it's not the way. As well to say never endo or always open. It's not the good way. There are some patients specifically that can benefit more with open compared to other patients that can be treated by endo. So my first strategy is Doppler ultrasound and to try to understand how is the flow from the aorta to the CFA, if there are stenosis in the iliac arteries or not, and finally decide, considering the type of the lesion you have in the common femoral. Still believe that coral reef plaques, anterior and posterior wall of the common femoral with no calcified iliac arteries, so clamping can be performed easily and safely in the external iliac and in the profunda, benefit much more from open surgery because you can remove the plaques compared to endo. But those cases can be performed by endo? Yes, sure, but with different results. If you're going to do IVL, so balloon dilatation with the shockwave balloon, IVL lithotripsy,
right,
to crack this calcium in these coral reef plaques is quite difficult to guarantee a good cracking and a good modulation of this common femoral compared to surgery that's gonna remove the plaques. For sure, if you don't have an acceptable result, you can finally put a stent, that it can be a good solution, good option. We have very nice results from a couple of trials with mimetic technologies in common femoral providing excellent results. But if I look at the patient like my father or my mother, so stent is going to be the second option in the common femoral for me. So if I have a very sick and diseased common femoral with calcium, coral reef plaques in anterior and posterior wall, I will send the patient to the vascular surgeon for an open surgery. If the vascular surgeon said, no, because so risk, blah, blah, blah. So for sure.
Well, especially in later stage diabetics, sometimes they don't heal as properly. And it's a really tough place. And we just had a patient that ended up, because I see it all the time with an infection that ended up getting in there. And they ultimately ended up just a couple weeks later after having the ENDART, because the infection ended up having an aortofemoral bypass that resulted from that.
Absolutely, absolutely. So if the surgeon refused the patient, I have the green light to go by endo. But still, I must to admit, this is my personal idea, this heavy calcified with coral reef plaques, common femoral, the outcomes are better in the surgery from the vascular perspective, without taking care about comorbidities, problems, complications, etc.
We
If
always
for
say,
sure,
go ahead.
no, it's for sure if the common femoral disease is different, so no heavy calcification, no coral reef plaques, soft plaques, hyperplasia, whatever. We have many options like vessel prep and DCB, vessel prep and mimetic technology stent, atherectomy. We have many options that allow us to manage in a very good way the common femoral.
Mm-hmm. And you know, we always tell patients that anytime you're deciding on which procedure to choose, if you do have a choice, we always say to err towards or lean towards a procedure in which there is a contingency plan, because there are some procedures where there's no contingency plan afterwards. You're going to lose your leg. For example, an axillary bifemoral bypass. We've had several of those where the doctors say, well, there's nothing you could do after this, so you're done. Just go ahead and lose your legs and die. I mean, that is what it is. But this one, especially in the common femoral, not that extreme. So my question is, if they choose to do the endarterectomy and go straight to surgical, what are the contingency plans when that fails? Because all procedures do fail at some point.
Well, this is a good point. Most of the vascular surgeons believe that open surgery for common femoral is relatively safe, so complications can be infection in the patch infection, groin infection, and so on. So probably surgeons must select the patients with a lower risk to have complications compared to endo, but I don't think so. They can have so complex or so difficult complications from the vascular perspective that could need a bypass. So, for example, if groin surgery finished in a bypass, uh, the patient selection was so bad, so bad. And I can't believe that I was 10 days ago doing a patient with a hybrid procedure. The vascular surgeon opened the groin, did an atherectomy, a punctured the patch, and did the SFA and pop quite fast and safe. So, as I said, planning is 100% of the succeed, probably with hybrid procedure or with an open surgery procedure. It's not possible that you finish in a bad complication in a groin that need a bypass. I can't believe it. So I think it's part of the planning and the decision making.
And if and when the endarterectomy fails, can you go back and do another endarterectomy, or can you do endo after? Because you can do an endarterectomy after endo, but can you do endo after an endarterectomy or redo the endarterectomy, or does it straight to bypass?
No, I think no, straight to bypass is, in my opinion, the last frontier. I can't remember the last time I sent the patient to a bypass for a bypass. I can't remember. So the time you do surgery, you did a surgery, if it's successful, it's gonna be a fantastic result with a very big common femoral that will allow us to puncture in it every time we will need, and so on. For sure, as every procedure, it can fail. If it fail, you're gonna have still a sick, small common femoral with many fibrosis around. So new surgery, in my opinion, is it's a must to be avoided. It's not a good indication because it's going to be more complex, more challenging, more difficult related to the previous surgery, the fibrosis, the scar, etc., etc. So probably endo is going to be the second option, and it's going to depend on the type of the result you have. If you can perform an endoatherectomy, endovascular atherectomy of this common femoral, that could be another option that could allow us to gain lumen and to have acceptable, functional common femoral just to go for a vessel prep and mimetic technology stenting.